Morning, everyone. Today I'm going to present a landmark trial, long-term results of RTOG 911, a comparison of three non-surgical treatment strategies to preserve the larynx in patients with a locally advanced larynx cancer. This trial was published in Journal of Clinical Oncology in 2013. Introduction. Over the last decade, results of prospective randomized controlled trials have changed the standard of care in clinical practice for management of locally advanced head and neck cancer. One of these trials, RDOG 9111, for resectable stage 3 and 4 cancer of the larynx, led to a change in the treatment paradigm for larynx preservation. From the induction cisplatin and fluorouracil, followed in good responders by radiotherapy to concomitant cisplatin. In 2003, they published the results of RDOG 9111, a comparison of induction here followed by RT, concomitant cisplatin RT, and RT alone after a median follow of 3.8 years. The goal of this trial was to determine the contribution of chemotherapy added to RT and the optimal sequencing of chemotherapy and RT to achieve larynx preservation. So the induction PF was a control group based on the results of the Veterans Administration Rangers Study Group trial. This is also one of the landmark trials in carcinoma analytics, in which they compared 3 cycles of reduction cisplatin plus fluorouracil chemotherapy and the radiotherapy versus the laryngectomy and post-operative radiotherapy, in which they found out that 2-year survival rate was 68% in both the treatment groups, indicating that the induction chemotherapy can be really helpful for larynx preservation. Now, in this trial, we reported the long-term update for 5 and 10-year results and analysis of pattern of failure, cause of death, and late effects. For patients and method, patient population, eligible patients had stage 3 and 4 squamous cell cancer of the supraglottic or glottic larynx, curable with laryngectomy and RT. T1 primaries and high volume T4 primaries were excluded about random assignment and treatment. Patients were stratified for site, source of or B stage and N stage, and then they were randomly assigned to one of the 3 regimens. The 3 groups in this trial. The group 1 is induction control arm, received up to 3 cycles of PF, which they given cisplatin 100 mg per meter square day 1 and fluorouracil 1000 mg per meter square per day for 5 days every 3 weeks. Responders who had 50% reduction of the primary tumor and at least stable disease in the neck received RT 70 grade 35 fractions. In group 2, we had concomitant, which is in which they received cisplatin 100 mg per meter square day 1, 22 to 43 of RT. In group 3 is the RT alone, in which they received 70 grade of radiation therapy. Salvage surgery was performed for patients in group 1, which is induction, who achieved less than a partial response at the primary site or who experienced progression in the neck after 2 cycles of PF or progression at any time during induction. Salvage surgery was performed in all groups in patients with biopsy-proven persistent disease after completing the RT or for subsequent recurrence. A planned neck dissection was recommended for the patients with N2 or N3 disease at initial staging. The patients underwent a comprehensive head and neck examination approximately 8 weeks from completion of the RT, every 3 months thereafter for 1 year, semi-annually during year 2 and 3, and then annually thereafter. Imaging of the neck was performed at the 8-week follow-up visit and then as clinically indicated. For results, a total of 547 patients were enrolled between August 1992 and May 2000. This analysis was performed after a median follow-up for surviving patients of 10.8 years. Only 11.7% of patients were alive with less than 10 years of follow-up. 1 patient with due consent and 26 patients were retrospectively declared ineligible. For a total of 520 advisable patients, 174 were assigned to the induction, 174 was assigned to the concomitant, and 172 were assigned to the RDO. 64% of the patients had stage 3 disease. Primary site was supraglottic in 69% of the patients. The end stage were distributed as follows: 32 comprised of 11%, T3 79%, T4 10%, and 0 50%, and 21 and then 28 and 3%. So this is a concert diagram. So randomly assigned patients. So 547 were randomly assigned to three groups, which is induction chemotherapy, in which 180 were assigned out of 547, in which including analysis for only 174, as 6 were excluded. In the RT concomitant with chemotherapy, 182 were assigned, out of which in the analysis 174 were included, and in the RT only 185 were assigned, and in analysis 172 were included. About late toxicity, radiology late toxicity scoring system was used. Subcutaneous, salivary gland, pharynx, esophagus, and larynx toxicities were the most frequent serious events. These complications led to the fatal events in all the groups. So 4 deaths were in the induction, 3 deaths were in concomitant, and 1 death were in RT alone arm. The 10-year cumulative rates of grade 3 to 5 late toxicities were 30.6 in induction, 33.3 in concomitant, and 38% in the RT alone. Any significant differences in the cumulative incidence between treatment groups were not detected. About preservation of the larynx, so a total of 148 patients underwent laryngectomy, including 55, 30 to 50, 55, which is 67.5% larynx preservation, 32 and 61 patients in the induction concomitant and RT alone respectively. 80% of the laryngectomies were performed during the first 2 years, out of which 84 was done in year 1 and 35 were done in year 2. Laryngectomy was performed for persistent or recurrent disease, except for 3 patients who were non-compliant with their assigned treatment and 9 patients with laryngeal dysfunction. The significant advantage of the concomitant cisplatin RT for larynx preservation persists as compared with the induction and RT alone treatment groups. The concomitant cisplatin RT resulted in a 54% relative reduction in risk of laryngectomy compared with RT alone, 42% reduction compared with the induction. There was no significant difference when compared RT alone with the induction. About survival outcome, overall survival did not differ in any of the treatment comparisons, with 5 to 10 year estimates of 58 and 39% for induction, 55 and 28 for concomitant, and 54 and 32 for RT1 respectively. After about 4.5 years, the curve began to separate favoring the induction, although the difference is not statistically significant. There was no significant difference in overall survival comparing patients who did and did not undergo salvage laryngectomy within 1 year of completing the treatment. An exploratory analysis showed a significantly worse survival for patients who had laryngectomy in both chemotherapy groups compared with those who did not, and no difference for RT alone. For disease-free survival, only the comparisons of concomitant chemotherapy versus RT alone reaches statistical significance, although the comparison of RT versus induction is close. So this is the 5 to 10 year estimates of efficacy endpoints. On the left side, these are the endpoints, and these are the 3 groups. So if we talk about laryngectomy-free survival, for 5 years and 10 years, the concomitant chemotherapy is shown superior for the 5 years, followed by the induction and followed by RT. If we talk about 10 years, the concomitant chemotherapy is followed actually by the induction. Induction is superior followed by concomitant RT alone. And all other endpoints from larynx preservation, local control, local region control, district control, and disease-free survival, concomitant chemotherapy was superior than the induction followed by RT. But when we talk about the overall survival, the RT with induction chemotherapy showed good results, followed by the concomitant, followed by the RT alone. If we talk about the graphs on the right side, these 3 lines, the yellow one is the RT with concomitant, blue one is the RT with induction, and gray one is the RT alone. So if we talk about larynx preservation, we can see the yellow line, which is the concomitant, is showing more laryngeal preservation than the induction. But if we see on the left side, as we can see on the left side, the laryngeal preservation, the second column, the RT concomitant with RT versus RT induction, we can see that there are more larynx preservation with a statistically significant result. If we talk about lumpectomy-free survival, we can see for the first 5 years, concomitant is showing good results as compared to induction. But after 10 years, we can see the induction overtakes and the concomitant graph drops. But if we see here in the lumpectomy-free survival, in the first curve, the RT versus concomitant versus the RT induction, we can see the results were not statistically significant. In the overall survival also, the concomitant chemotherapy RT, after 10 years, the graph is even below the RT. And when we see the hazard ratio, we can also again see that as a hazard ratio of 1.25, and also the result was not statistically significant in the overall survival. About local regional control, the concomitant chemotherapy was way superior than the induction and the RT. The pattern of result first failure, 228 patients died without recurrence or are alive without recurrence. The proportions of patients in the induction, concomitant, and RT alone groups with recurrence and the site as a component of recurrence were as follows. So local recurrence was 33.3% in the induction, 22.3% in concomitant, and 35.8% in the RT alone group. Our regional recurrence 7.6 was in the induction, 3.3 in the concomitant, and 11.5 in the RT alone group. About distance, 10.4 was in the induction, 11.2 in the concomitant, and 14.9 in the RT alone group. Concomitant cisplatin RT resulted in a 41% reduction in the risk of local regional failure compared with the RT alone, and a 34% reduction compared with the induction. Here's a survival graph. So blue line tells us about no lumpectomy happening, yellow is the lumpectomy, and it's compared the survival. So P is for the induction, C is for the concomitant arm, and D is for the radiation alone arm. When we see in the induction arm, we can see that the survival is more when no lumpectomy is happening, and in the concomitant arm, also the same result for survival with no lumpectomy. When we compare to the radiation alone arm, we can see that when lumpectomy was done, the survival was more as compared to the arterial alone arm. About distance metastasis, chemotherapy given concomitantly or as induction showed similar benefit for achieving distance control, but neither comparison is statistically significant. The distance recurrence rate was low, with 28, 29, and 41 patients experiencing distant recurrence in the induction, concomitant, and RT alone groups respectively. What cause of death? A total of 374 patients have died. The RT alone group had the highest proportion of deaths attributed to larynx cancer, and the concomitant group had the lowest. More deaths were classified as unrelated to either larynx cancer or treatment in the concomitant group, compared with the induction group and the RT alone group. Whereas the proportion of the deaths classified as unknown, not reported, was similar for all groups. They conducted an exploratory analysis of death caused by study cancer and death not caused by the study cancer. There were no statistically significant pairwise differences between the treatment groups for death caused by the study cancer. However, for death from causes not related to the study cancer, there was a significant disadvantage for the concomitant group compared with the induction group. So this is a table which have shown the cause of death. So as we can see, cancer under study, there are more deaths in the RT alone group, followed by the induction and followed by the concomitant. But when we see the deaths unrelated to cancer or the treatment, there's a rising deaths in the concomitant, followed by the induction, followed by the RT alone, which might be the reason of decrease of overall survival in the concomitant. In the right side, the survival graphs, we can see the left side, the A is a death from the study cancer, and B is the death not caused by the study cancer. So we can see when we see deaths from the study cancer, the 10-year results are the induction followed by survival is more induction followed by concomitant followed by the RT. Whereas when we see the deaths not caused by the study cancer group, we can see the survival is more in the induction followed by RT and the concomitant arm is at the bottom. The discussion. Intergroup trial RTO 911 designed more than 2 decades ago compared concomitant cisplatin RT and RT alone with a control group of induction PF followed by RT. The composite endpoint of LFS was chosen as the primary endpoint. For this outcome, treatment with the concomitant cisplatin RT compared with the induction is not significantly different and treatment with RT alone is significantly inferior. More deaths in the concomitant group were unrelated to the larynx cancer. This occurred with no apparent increase in the late effects. This raises the possibility of fatal treatment-related episodes not identified with the current system for monitoring and the grading late effects. So they did not collect the information on gastrostomy tube usage. Few patients were limited to liquids or unable to swallow. And the most patients in this trial were treated with simple two-dimensional plans. Whether that risk would be the same with today's RT technique, which is 3D or intensity modulated RT, which provide much more conformality and normal tissue sparing, is relevant. For conclusion, in conclusion, the long-term results of intergroup RTO shows that the composite endpoint of LFS, induction, and concomitant treatments have similar efficacy. However, local regional control and larynx preservation was significantly improved with the concomitant treatment compared with induction or RT alone. No difference in late toxicity or speech or swallowing function were demonstrated, but there was an unexplained increase in death unrelated to cancer in patients who received concomitant cisplatin RT. This may be responsible for the absence of survival advantage for the concomitant treatment group. For intermediate stage larynx cancer, if strategies focusing on improved local regional control should be undertaken and better assessment